the JAMA Network.
My name is Carolina Malta Hansen. I am a doctor and a research fellow at the Duke Clinical Research Institute. Out-of-hospital cardiac arrest is a major public health issue affecting about 300,000 Americans every year, of which less than 10% survive. The chances of survival fall about 10% per minute without any intervention, but early cardiopulmonary resuscitation, CPR, and/or defibrillation can increase the chances of survival remarkably. Despite this, the proportion of patients who receive any intervention before arrival of the emergency medical services, that is CPR or defibrillation, remains very low and very different across regions in the United States, resulting in very different outcomes for cardiac arrest patients across the country. Our objective was to assess temporal changes in bystander and first responder intervention in North Carolina from 2010 through 13, including the combination of bystander and first responder interventions, for instance, bystander-initiated CPR and first responder defibrillation. And secondly, to assess the association between bystander and first responder intervention and survival. As part of the Heart Rescue Project, the North Carolina Regional Approach to Cardiovascular Emergencies team, the RACE team, initiated statewide multifaceted interventions to improve cardiac arrest care and outcomes in North Carolina in 2010. Following these initiatives, we identified all out-of-hospital cardiac arrest patients through the Cardiac Arrest Registry to Enhance Survival, the CARES Registry, from 2010 through 13 in counties with complete case capture. We only included cardiac arrests of presumed cardiac cause, and we excluded all those with do not resuscitate orders or cardiac arrest witnessed by 911 responders. To assess whether missing data had an effect on our results, we performed the analyses using imputed data sets, using multivariable imputation with chained equations, and compared those estimates to the estimates from the observed data set. During this 4-year period, bystander CPR and first responder defibrillation increased by about 25%, and the combination of bystander CPR and first responder defibrillation almost doubled during the same period. We found that survival to discharge increased also by about 25%. However, this increase was only observed for patients who received bystander CPR. And finally, that patients who received bystander or first responder interventions were more likely to survive compared to patients who received EMS interventions alone. The important next steps in this research are to see whether these benefits were seen across different groups, for instance, across gender, race, socioeconomic status, or across different regions of a state. It would also be important to see whether these improvements were seen in other different areas in the United States. And finally, we need to address the low bystander defibrillation rate. So the next steps would also be to assess how we can improve bystander defibrillation.